Hi there. So I'm going to be speaking about my client Sophie with linking to congenital adrenal hyperplasia. I'm going to call it CAH throughout this as it is quite a large, long word to continue to talk about. So my holistic assessment is Sophie is a 28-year-old female presenting with postnatal depletion, low vitality and PTSD post-birth of her twins 8 months ago. So she also has a diagnosis of CAH, which she was diagnosed when she was young. During the consult, there were no red flags presenting from her. However, 8 months ago was her excitatory factor, where she birthed 2 twins prematurely at 28 weeks, and she only had the survival of 1. So this was a very traumatic birth due to the loss of life of one of her newborn daughters, and it was also an emergency C-section due to the premature of the twins. The diagnosis of congenital adrenal hyperplasia may be contributing to her symptoms of fatigue and her inability to lose weight. She has high cortisol and adrenal dysfunction, which is sustained by the post-traumatic events of her birth and the ongoing impact of her daughter coming home following her birth. She has the sustaining excess body weight that the client is wanting to use. However, this ongoing excretion of cortisol from her CAH may also be an excitatory factor to Sophie's case. Her symptoms also linked to CAH is her irritability, her low mood, brain fog, and that's all also linked to her postnatal depletion, low sleep, and her PTSD. So overall, Sophie's case is presenting with complex symptoms that is very likely related to her CAH. As well as her postnatal depletion, her adrenal dysfunction, and her PTSD from post-trauma from her birth. So, in summary, around the CAH, which is linked to Sophie's case, is the pathology around CAH is an enzymatic deficit that occurs at birth, where the enzymes are needed to synthesize cortisol from the cholesterol in the adrenal cortex have a genetic mutation. The cortisol synthesis causes precursor buildup, hypersecretion of the adrenal androgens that results in low cortisol with high ACTH that then has an ongoing risk of adrenal crisis. This is the biggest thing to look out for in this condition, and it plays a very delicate role in the shifting of this delicate homeostasis between the hypothalamus, the pituitary, and the adrenal glands. And these have been very much triggered during pregnancy and then also post-birth, but also the adrenal glands around the loss of her daughter, a traumatic birth, and also her CAH as well. So in this case, no red flags were presented. However, if another client came in with CAH, some of the other things that you would be looking out for red flags, the biggest one is severe dehydration, vomiting, diarrhea, and hypotension. And this is the biggest red flag, as it can indicate adrenal crisis and possibly shock. If this comes up in a consult, I would be referring to the doctors or emergency department straight away. Other ones that are red flags for this condition, if someone is not aware of it, would be hyperpigmentation of the skin and mucous membranes, which is indicated by elevated ACTH levels. If they're short in stature, if they were younger kids and they are lacking the growth and indicating that their growth hormone is deficient and that they're having that failure to thrive. They also can have an electrolyte abnormality and imbalances, most deficiencies. They can also have delayed or absent pubertal development and would be more indicated with Sophie's case if she was having infertility issues as well. But as mentioned before, the biggest red flag to look out for is severe dehydration, vomiting, diarrhea, or hypertension because of the adrenal crisis. Other differential diagnoses for Sophie's case, as well as the CAH, would be adrenal insufficiency, Cushing syndrome, hyperaldosteronism, pituitary disorders, thyroid disorders, either hyper or hypothyroidism, PCOS, polycystic ovarian syndrome, premature ovarian failure. So if these were to come in, and in Sophie's case, other investigations that I would be looking out for now would be her ACTH levels, her serum electrolytes, her renin and aldosterone levels, her 17-hydroxy progesterone levels, her cortisol levels, her testosterone, her DHEAs, her luteinizing hormone, follicular stimulating hormone, and a pelvic ultrasound to rule out PCOS. And then also potentially, if money wasn't an issue, we'd look at genetic testing to confirm this diagnosis if she didn't know she already had it. Because if we're wanting to confirm congenital adrenal hyperplasia, it would be one of the big findings. It would be the 17-hydroxyprogesterone levels. Her androgens would also be, so her elevated 17-hydroxyprogesterone levels would be elevated. Her androgens like testosterone and other DHEAs would be high, and she would have an electrolyte imbalance. So just some articles and research that support the case, and Sophie's case with CAH would be that Meitel et al. Did a study in 2021 that demonstrated that congenital CAH can initially present in pregnancy, which are symptoms that are often mistaken as preeclampsia, and postnatally they can sometimes go as just postnatal depletion and both postnatal depression. So it's important to highlight that this could be an option for her, and looking in that was a study that found that. Another one is Fellhammer et al. Did a study in 2018 where they did a cross-sectional study of 161 adults with CAH diagnosis, and they had an increased self-reporting of fatigue, and that was significantly associated with the degree of adrenal insufficiency. So that was determined by blood work. So that's another one indicating that Sophie, with her high levels of fatigue, can be a possible indicator. And also another one just around more the fatigue as well. The Marathon, Gangini and Merck did a study in 2022 that had 202 children diagnosed with CAH that had 38% reported that fatigue was the most common presentation initially, and that it's the key early clinical manifestation. And the recognition of this can prompt diagnosis and treatment to then reduce the risk of preventing an adrenal crisis. So relevant around Sophie's case with all of these in the research as well, she's a postpartum woman that was recently diagnosed with CAH, and the ongoing symptoms of her exhaustion, her inability to retain normal energy levels can be related to her CAH itself, and her fatigue issues, if they look at steroidal treatments that align with these studies, it might find that she has a common support that might be also another form of treatment to think about. And it just reinforces that this is a very specific type of condition, and the treatment needs to be reviewed accordingly. And it's quite a big red flag for us to highlight, because that risk of adrenal crisis in this condition is quite high. So the other things within this that I want to talk about is the practicing overseas and the questions related to that. So if I was to be practicing overseas, it is very dependent on the country that I go to, as some naturopath qualifications that I gain in Australia may not directly transfer for licensing purposes into other countries. So I might have to do additional examinations or trainings, or I need to potentially do a full completion of studies. It's very dependent on the country that I go to, and the scope of practice that I would do would also vary widely, as some countries allow naturopathic prescribings the same way, some don't, and some nutritionally wise also might be different. For example, in the UK, they don't do herbal prescriptions with blending herbs, and in the States, you can't create a merged herbal liquid supplement like we do. They only just sell standard herbs. So those things would have to be considered depending on where I go. So I would very much have to research, and I would have to find the associations within the country and determine that there. However, if I'm in Australia and I'm doing telehealth to people overseas, again, it would be determining the amount of prescribings that I can do for that country, as I would be posting it there. So you would need to make sure that it gets approved. However, the scope of the nutrition, the lifestyle and the well-being can be completed from my trainings within Australia and the scope of practice within my Australian trainings. The only other thing would have to be determining around language barriers and cultural differences. So I've had people come in here and I have to be culturally acceptable and meet them where they are. So it would be the same, just making note of those with the telehealth where they are. And around overcoming these limitations, I think it would be very important within the country that I am seeing clients to very clearly communicate my scope of practice in limitations of living in Australia and treating someone overseas, and what we can expect and what we can't do, what I can do, what I can't do, and having a very clear understanding of that. Using translations where required, if I need to do a translator, or whether we need to do subtitles in their language would be another thing. And then also if I need to provide further details of local practitioners and find out who's in that country, and if they have doctors or if they have a nutritionist or a dietitian, making sure I collaborate with them as well would be my other thing. Thank you.